Welcome, everyone. Thank you for joining Continuous Learning with Bioguard. It is my pleasure to introduce our webinar speaker, Dr. Chen Xilin. Dr. Lin got her DBN degree from National Taiwan University and her PhD from the College of Biological Science and Technology, National Jiao Tong University. She's a professor in the Department of Veterinary Medicine and director of the Zoonosis Research Center at National Taiwan University. In addition, she is a former director of the Animal Disease Diagnostics Center at National Taiwan University. Her specialties include veterinary clinical microbiology, clinical pathology, and animal cancer biology and therapeutic development. In today's lecture, Dr. Lin will discuss coagulation disorders in dogs and cats, emphasizing their diagnostic and therapeutic challenges. The presentation covers species-specific variations, diagnostic tools like aPTT, PT, treatment options such as vitamin K1 and plasma therapy, and the importance of pre-surgical screening. We are thrilled to have her as our speaker for this webinar. Without further ado, please join me in welcoming Dr. Lin.
Hi, good night, everyone. Thank you for the introduction from Dr. Luo. I'm Chen Xilin from National Taiwan University. So welcome everyone to our talk today. So let me share my slides. Okay. So can everyone see my slide right now?
Yes.
Okay, thank you. So welcome you to my lecture share today, and I will focus on the coagulation disorders in dogs and the cats. And so over the next hour, we will define hemostasis and its three phases, including primary plaque formation, fibrin clotting, and fibrinolysis. And we will also dive deep into immune-mediated thrombocytopenia from the so-called ITP. So from the pathophysiology to advanced therapy. We will also cover breed-specific inherited disorders, the so-called von Willebrand disease, hemophilia, platelet function defects. Also, we'll demonstrate novel diagnostics such as platelet function assays and the TEG, this kind of functional assay. We'll also highlight emerging treatments, including thrombopoietin receptor agonist and the direct oral and anticoagulants. My goal is to arm you with the latest evidence-based strategies so you can immediately apply them in your clinic. So here we go. So the topic today on hemostasis here as the body's way of balancing bleeding and clotting. So for the in the whole process, it will increase the balance among protein cells and the vessels, blood vessels, to stop bleeding. So for the for the hemostasis, the whole process will include primary hemostasis, secondary hemostasis, and the fibrinolysis. So for the primary hemostasis, platelets stick together to damage endothelium and form a loose plug. And then come to the secondary hemostasis. For the secondary hemostasis, the coagulation cascade cements let plug with fibrin. So they go to the coagulation and go to some procedure of wound healing, and then go to the fibrinolysis. So once the blood vessel is repaired, plasmin breaks down clot to restore fluid. So this is the whole process of homeostasis. So understanding the steps helps us pinpoint whether a bleeding issue is platelet based, clotting factor based, or fibrinolysis problems. Immune-mediated thrombocytopenia occurs when autoantibodies destroy platelets. And sometimes, as not only destroy platelet, it will sometimes also they will attack megakaryocytes. Primary that's the because megakaryocytes will produce is the major source of platelet. So sometimes basically they destroy platelet, but sometimes they also attack megakaryocytes, and the place they attack this kind of cells will be basically in spleen and the liver. So as we focused on immune-mediated thrombocytopenia, so-called IMT or ITP, we can call them ITP in short. So if we want to know more about ITP, we can start from the pathogenesis. So basically, there are two kinds of ITP, primary versus secondary. So for the primary ITP, the pathogenesis most of the time is idiopathic. That means we don't have any idea about the case, but they just happens with this kind of decrease, giant decrease of platelets. And for the secondary ITP, usually that's what we found in the clinical site. So secondary ITP follows some specific triggers, including infection. And this infection, most of the time we see in canine cases will be an Ehrlichia and anaplasma infection. So secondary to this kind of infection, then we can find ITP in some cases. And also some specific drugs as well as tumors. So when infection, when improper drug treatment, and the neoplasia, so we will find it. Then we will followed by the secondary ITP. So all this no matter primary or secondary ITP, most of the cases was common found in dogs and rare in cats. So it's the most common acquired bleeding disorder in dogs. So cats get it rarely and almost always secondary. So clinically, you will see some specific clinical signs such as PTK8 and ecchymosis, as well as mucosa bleeding. And sometimes you may also find meninema, hematuria, and this surface bleeds distinguish immune-mediated thrombocytopenia ITP from deep cavity hemorrhages. Okay, let me try. So for the diagnosis of immune-mediated thrombocytopenia, their systemic exclusion is very important. So we will need to confirm the true thrombocytopenia by blood smear to rule out the clumping artifact. And also we need to screen for potential infections. We can use PCR, we can use serology for what we have mentioned before, Ehrlichia, and Anaplasma, Babesia, as well as Rocky Mountain swine fever. This kind of infection will result in secondary ITP. And also we need to review the drug and the vaccine history for these patients, because specific drug or vaccine treatment may interfere the immune balance of these cases and triggers the secondary ITP. And we can also use imaging tools such as radiography, such as ultrasound, to help us rule out a clot, neoplasia, and the spleen disease. So bone marrow aspirate if you suspected this case as a result from decreased production rather than platelet destruction. So in these cases, you may try bone marrow aspirate. So another tool that we can use is about the anti-platelet antibody. And this anti-platelet antibody test can support the diagnosis of ITP, but it just provide us about the supportive evidence, not the definitive evidence, because a negative result does not rule it out. Only the clinical context rules. So when we mention about the ITP treatments in the first line, the first choice is try because it's immune-mediated. So we need to reverse the imbalance of the immune situation. So on the first line, immunosuppression we used is a high dose prednisolone. The per day of for dog cases, per day per kilogram 2 milligram the prednisolone could be used. So most dogs respond in around 5 to 7 days. And also we can add second agents such as azathioprine, cyclosporine, as well as mycophenolate mofetil if needed. So sometimes we may also need vincristine. Use IV push vincristine. That's maybe suggest dose will be per kilogram. 0.02 milligram vincristine with IV push. It can rapidly boost platelet release, and it can shorten time to save counts of platelet by around 2 days. But please be careful that we need to avoid use vincristine in MDR1, that means multi-drug resistance 1 mutant breeds. In this kind of MDR1 mutant breeds, we should not use vincristine for the treatment. So the specific breeds such as Collies and Australian Shepherds, because they are belong to the MDR1 mutant breeds, so treat them with vincristine or some specific drugs may result in the over accumulation of this drug within their bodies and to result in some severe drug toxicity. So for the ITP treatment, the first line we use prednisolone. We can use some second agents, and we can in some dogs, some specific dog breeds, we use vincristine for boost the rapid platelet amount. However, if the cases still severe, we may move on to use IVIG. So IVIG is kind of immunoglobulin, and the IVIG is cost us a lot, but it can arrest severe bleeding by saturating Fc receptor on the macrophages, on those phagocytes. So it can reserve, so it can save this situation to prevent the macrophages keep to phagocytes, these kind the platelets. So preserve it for life-threatening cases. Or Vincristine contraindicated dogs. So that's what we used for the ITP treatment. So in addition, we may need to provide some supportive care like cage arrest, like gastroprotectant, like RBC transfusion if the case is under anemia condition. And rarely, in some cases, in very rare condition, that we may treat the cases with platelet transfusion or lyophilized platelets in critical hemorrhages. So after treatment, we need to monitor these cases and to predict the outcome in ITP patients. So monitor platelet daily in hospital actually is very critical. So a rise above 50 times 10 to the third power per microliter typically marks risk reduction for spontaneous bleeds. So that means our treatment actually is going to work at this time. And so the expected response will around 5 to 7 days. Because in our first treatment we use prednisolone, so after the condition get better, we may try to taper steroids and adjunct immunosuppressives over months, and checking platelet every 1 to 2 weeks initially. So short-term survival, that means the case could be go to discharge. Actually, it's around the 17 to 90 cases will be get good prognosis, but most deaths occur early from catastrophic bleeding or complications. So after treatments and after the cases to be discharges, sometimes relapse can happen. So teach the owners. It is very important to teach owners to watch for if there are any PTKA, that means is any red, blues on the skin or on the belly. These things it's very important to teach the owners to notice these symptoms, and please ask them to return promptly if bleeding recurs again. So we will show some case with the dog suffer from ITP. This case is a 4-year-old Cocker Spaniel, and presenting with PTKA and a platelet count of maybe around 10 and 12 to 10 or 12 times 10 to the third power. They have the normal PT and aPTT responses, and the tick-borne disease testing were all negative. So bone marrow aspiration showed abundant megakaryocytes. So this constellation confirms all this diagnosis and all the diagnosis results confirms primary ITP. So yeah, that's what we do. This is what we can, well, what we see from the clinical science and what we found from the lab test and as well as the bone marrow test. So now we got the primary ITP cases. So what we're gonna do for the next stage? So we can use the following flowchart. So if the platelet, because the platelet right now, if they below maybe around 30,000 or there is active bleeding, we can initiate. It can initiate maybe prednisolone, just as we mentioned in the previous slide, that per day per kilogram 2 milligram, and plus vincristine with IV push. So monitor the platelet count daily. So if no response by day 5, add a second immunosuppressive agent. If no response, so we will add the second immunosuppressive agents such as mycophenolate or cyclosporine. So then maybe it will help the cases to get better and the rebound of the platelet amounts. So for the refractory cases, and sometimes this refractory cases may with life-threatening hemorrhages. So during this time, we may consider IVIG or thrombopoietin receptor agonist. So once a response, after the treatment, once the response is achieved, taper steroid gradually over 3 to 4 months. So that's the treatment protocol when we face the ITP cases. So the above slide show us about the immune-mediated thrombocytopenia. So basically, the pathogenesis of immunothrombocytopenia is because of the some specific mechanism that interfere with the balance of the immune system. So the immune cells, such as the phagocyte, basically phagocyte, will start to engulf all these platelets, or they will destroy the megakaryocytes. So what we do is try to do some immunosuppressive agents, try to interrupt this procedure, and on the meantime, we will also use some drugs such as vincristine to boost the platelet. But please be careful that in some specific breeds, such as Collie, we've mentioned, because they have the MDR mutant, so we should not use vincristine on this kind of cases. So the next day, we will try to introduce is about some breed-specific disorders, especially in dog cases. So this is the first disease we want to introduce is about the von Willebrand disease, the so-called VWD. So VWD is the most common inherited bleeding disorder in dogs. So this disease actually results from the deficiency of VWF factor, which is responsible for hemostasis. So there are basically three kinds of VW von Willebrand disease. So type 1 is about, because this disease is resulted from the deficiency of VWF. So we can start from the pathogenesis. So for the type 1, actually, this is the most common. This is the most common cases that we've found. For the type 1 VW disease, in this case, we will find the partial VWF deficiency. It's very common in Dobermans. So actually in Dobermans, there will be up to 70% of Doberman dogs carry this kind of mutation. That means in Dobermans, actually they show they are very common to find this kind of disease. Also, there's type 2 VWD. And for the type 2 cases, we can find it's related to the abnormal VW factor function. And actually, these rare cases to suffer from the type 2 VW disease. And the third type is type 3. And type 3 cases, it's very severe situation that we found almost a few VW factors in these dogs. So these dogs will show severe bleeding symptoms. But fortunately, this is in rare cases. So how to diagnose the VW disease? So we can find in these cases, the dogs may show typical symptoms, like they will show the prolonged buccal mucosal bleeding time. And if we have the ELISA assay for detection, the concentration of VWF antigen, we could find in these cases that within their blood, the VW factor concentration is really, really low. And the defect and the really rare amount, as well as the defect function of VWF, actually is result from their genetic mutation. So we can perform some DNA tests to identify if this case is really come from the gene mutation of VW factors. So that's what we diagnose about this kind of disease. So after the diagnosis is made, so the next step is about the management. So as we mentioned before, because most of the cases actually they suffer from type 1 VWD. So the basically the treatment will be we can use DDAVP. I think as you already know that this is the vasopressin agonist. So this kind of DDAVP drug, they can make endothelial cells to release the VWF as well as possible. So it will to boost the endothelial cell to increase the VWF concentration. We can also use sometimes if we after in addition to use DDAVP, we can also use cryoprecipitate. So cryoprecipitate because within cryoprecipitate it's rich in VWF factor as well as coagulation factor 8. So it will active the bleeding. It will activate the coagulation protocol, and it will help us to prevent the active bleeds. So it's the management as well as the treatment. So after the if the case is recover well from this round of treatment, and later we need to warn the pet owners that please avoid trauma and plan and the surgery plan very, very carefully in this kind of dogs. So This is another case about the VWD, and this talk about if this dog suffer from VWD disease, but this dog she still need to do some surgery. So what should we do? What should we manage to help the dogs to safely recover from the surgery? So this is the 8-year Doberman spay prep. So we found the mucosal bleeding time is around 7 minutes. And she had a prior history of bleeding after minor trimming. So tests showed the 8 minutes, 7 minutes actually is longer than the normal time. And the VWF concentration is just around 15%. So we administered, actually, what we can do is try to administer DDAVP before the surgery, because the dogs, they need to do some spay surgery. So before the surgery, we can give the before the surgery, we can administer DDAVP IV push. And during the surgery and post the surgery, post the surgery day 1, we can give some cryoprecipitates. And as we mentioned before, because cryoprecipitate, they are rich in VW factor and factor 8, so it can help dogs to prevent the potential bleeding. So the outcome is from the beginning and at the end of the surgery, even after the surgery, we can find there's no bleeding complications in these cases. So for the dog suffer from VWD, we still need to do some what we can do, try our best to use some specific drug and do some specific plasma, such as cryoprecipitates, that will help us to control, to maintain the whole hemostasis of this kind of dogs. So another breed, so VWD is breed specific coagulation problems. So another breed specific disease, what we will talk about, is about the Hemophilia A and the Hemophilia B. So as we know that all the coagulation cascade actually is consists of different kind of coagulation factors. So for the Hemophilia A and B, they are because of their gene mutation. So for the Hemophilia A patients, these cases, they suffer from factor 8 deficiency. And for Hemophilia B, they suffer from factor 9 deficiency. So this kind of patients, they present the typical symptoms will be the such as hemarthrosis, that means the joint bleeding, and large cavity hemorrhages, for example, hemoabdomen. So we can see the joint bleeding and the hemoabdomen in this hemophilia dog cases. So this kind of gene mutation actually is X chromosome linked. So they will result in clotting factor 8 and 9 deficiency, and basically it affects males predominantly. Okay, so so that's why we found the clinical symptoms. So for the diagnosis, we confirmed the prolonged aPTT, but with no more PT time, and confirmed with some specific factor assay. Just as we mentioned before, we can use the ELISA kit to measure the factor 8 and the factor 9 concentration within the blood to confirm confirm what we to make us to jump to the final diagnosis. So how to manage this kind of cases? So again, we can use cryoprecipitates because they are rich in these coagulation factors. And and sometimes we can use plasma transfusion or fresh frozen plasma, either transfusion, and when the case are bleeding. And we also need to take care that to avoid these dogs, these cases suffer from trauma, and consider potential gene therapy that will reverse the deficiency of factor A and factor IX and protects these dogs to reverse this kind of gene defects. So so far we've provided two kind of breed specific disease such as VWD and such as hemophilia, and in fact, there are still other inherited or platelet function disordered that were happened in specific breeds, such as the factor 7 deficiency in beagles. So when this case happens, we can find prolonged PT, prolonged thrombin time in beagle cases. And also in some cats, there is also factor 12 deficiency. And this is a kind of inherited disease, but with benign prolonged aPTT. And also we can find the glands from Basthania. And so this is the, because this disease actually is found in otter hounds. And for otter hounds, we can find in otter hounds as well as in great Pyrenees, And this kind of disease actually is also from the gene mutation, and the result will be the defect expression of some specific glycoprotein on platelet. And this glycoprotein will increase glycoprotein 2B and 3A. So this kind of defect expression of GB, glycoprotein 2B and 3A on platelet will result in the not very well aggregation of the platelet. That means their primary coagulation actually it doesn't work very well. And another is about the Scott syndrome. Scott syndrome is specifically found in German Shepherd. So in these cases, we can find the dogs will suffer from mild bleeding due to the phosphatidylserine defect. So what is phosphatidylserine? Is actually the component within the cell membrane, inner cell membrane. So without this phosphatidylserine, it again will result in not very well aggregation of the platelet. So again, the primary clotting doesn't work very well. So another breed is Cavalier. So Cavalier, sometimes they can show macrothrombocytopenia. So this cases when the Cavalier suffer from macrothrombocytopenia, we can find low platelet count but giant platelet and no bleeding. No specific bleeding symptoms. So it is a benign cases, and most of the cases actually they don't need any treatment, but just on the blood smear we can see very giant platelet, but their function is actually not work well. So what we've mentioned before is about the some specific some hemostatic disorders that focus on dogs. And in cats, actually, yes, we can also find the cases, but due to the time limit, so today we focus on dogs mainly, and we provide some specific breed-specific diseases. So now we will move on to the diagnosis. What kind of tools we can use to help us diagnose with to monitor the platelet function. So I think most right now the most common tool we use is TEG, the Thromboelastography that we use. So TEG actually is a real-time assessment of clot formation and clot strength, and also as well as the fibrinolysis. So it can help us to monitor the all procedure of this homeostasis. So so it helps a lot with this kind of functional assay. So there are specific key parameters. So for the R time, it means time to initial fibrin formation. So it helps us to identify the coagulation factor activity. And for the K time and the alpha angle, it will help us to monitor the clot kinetics. So actually, during these two parameters, we can know the fibrinogen as well as the platelet function. And then the next parameter will be MA. The MA is clot strength. So clot strength will help us the clot strength actually reflects the platelet contribution. So it's very important. And finally, is about the LY30. LY30 is the percentage lysis at 30 minutes. So it will help us to monitor the time, how much time we will spend for fibrinolysis. So the data we've obtained from TEG actually will guide us about the about how we like it will guide what we need plasma, what we need platelet, or some specific transfusions, and we can apply them in cases suffer from trauma, DIC, and hypercoagulability. So most of the time you can use TEG, but we can also use some advanced coagulation profiling. So for example, we can use D-dimer. And D-dimer actually is a result from the it will usually elevated in thrombosis or DIC. So it's a negative rules. Negative data help us to rule out thromboembolism. So we use D-dimers can help us to support thrombosis diagnosis. And the some new tools that still in research is about the thrombin generation assay. For the thrombin generation assays, we can measure thrombin bursts, and it could help us to monitor the procedure and help us to monitor the concentration of thrombin. And another assay we use is the anti-XA assays. This assay will help us to monitor if we want to treat specific drugs such as low molecular weight heparin, as well as DOACs. DOACs are referred to rivaroxaban. So if we want to use this kind of drugs, and using this kind of assay will help us to tell the dosing, the proper dosing. So this is a different kind of coagulation methods that we can use. And there are still some markers such as TAT that stands for anti-thrombin complex, as well as fibrinogen degradation products. So this kind is a marker to help us if the specific this kind actually is to tell us what the specific stage that for the hemostasis and as well as about the coagulation problems. So these two refined our assessment of clotting and the fibrinolysis beyond the PT as well as aPTT. Okay, so after we know some about the diagnosis tool, so we can move on to some specific treatments thing that we here okay. After we will diagnose about the hemostatic problems, so we can use some specific treatments. So right now there is some novel treatments that about the TPO. TPO means the thrombopoietin receptor agonist, as well as antifibrinolytic things. So for the TPO receptor agonist, right now, as about the romiplostim and the altombopac in refractory ITP. So it's this finding is catched from some specific case reports, and these cases the dogs suffer from recurrent ITP. So in these cases that they try to use this kind of TPO agonist, and they can find the much better outcome than the traditional treatment. And for the electrobombac, it helped. Actually, in one case report, it helped in one dog with aplastic pancytopenia. So now the drug we use is a tranexamic acid, the so-called TXA. And the TXA drug is effective for hyperfibrinolysis because it will blocks. It blocks fibrinolysis, and it will use perioperatively in greyhounds and trauma case. So that's what we use. So this treatment actually is only what we found in case report. So we need to it may have efficacy in ITP cases. However, we still need to take care and monitor the potential side effects for this kind of new treatments that we use. So the above novel treatment actually will expand our aerosol for difficult cases. So that's the some of ideas that to help us to solve the problems. Sometimes the cases, sometimes we face the severe cases. So component therapy is now standard in many referral centers. So such as cryoprecipitate that we mentioned, it can pretty useful for the treatment for VWD as well as hemophilia, because this cryoprecipitate, they are rich in coagulation factors, and we can also use the lyophilized as well as fresh platelet concentrates for critical thrombocytopenic bleeds. So that's I think that's one of the good choices that we can use. And in some cases, if the dog is suffer from, maybe not dog, maybe also in cats. If this animal that suffer from refractory immune-mediated cases, we may need to do some plasma exchange, and it will help us to wash out the such as autoantibodies, and to prevent these autoantibodies to keep attack the platelets or the megakaryocytes. And what we've mentioned that right now some different kind of gene therapy is on the way, so we can also consider about if we can have this kind of gene therapies and for reverse some hemostatic problem that are result from genetic defects. Okay. So actually we have the what we have right now, we have a different kind of treatment choices that we can use. We have the complete diagnostic procedure to help us to identify which stage the problem is, in which stage during the hemostasis. So after that, we have the treatment scheme that help us. We have different kind of treatment choices to help us. So there is also some direct oral anticoagulants that are used in dogs and cats. So for example, for the rivaroxaban and epiaxaban, as for this drug is designed for hypocoagulable patients. And what is this kind of two drugs? These two drugs actually is factor XA inhibitors. So this study have shown that they are safe, predictable. They have show safe, predictable anti-XA activity in healthy dogs. So this kind of drug treatment actually could help us, could be used in patients suffer from hypercoagulation. And also the anti-XA assay, we have right now, actually we have anti-XA assays now available to monitor the treatment effects. So we got some pharmacokinetics data and the safety data of this kind of two drugs. So we also use this kind of assay to help us if we treat them with the proper dose. Also, we can use some specific for us to monitor the potential outcome. So right now, actually, in high-risk cases, we can use this kind of direct oral anticoagulants with clopidogrel and to help us. For example, for the immune-mediated hemolytic anemia cases, we can use this kind of combination to help them maintain their healthy condition. So, the benefits of this kind of drug about the direct oral anticoagulants actually is the response from owners is good because they tends to their compliance is better with oral medications compared to an injection such as low molecular weight heparin. So the take home our briefly conclusion here is try to remind us about the actually for the ITP immune-mediated thrombocytopenia, we have the evidence-based protocols either for diagnosis or treatment, and this kind of procedure will improve the survival of the animals. So we also need to really take care about the breed risks because different breeds they may suffer, but tends to suffer from some specific genetic diseases, so such as VWD, hemophilia, and other breed-specific hemostatic disorders. So we need to know all this background information and to do some tailored diagnostic as well as treatment. So right now we have the advanced diagnostics such as TEG, such as PFA. They were enable us to tailor the targeted therapy for the better outcome of this kind of dogs. So what we mentioned before, that we have the TPO agonist, we have the direct oral anticoagulants. It helps us expand our tools to design the better strategy for treating the coagulation problems. So here is my talk today. If you want further information or some specific diagnostic tools you want to use, you can follow the Bioguard company, and they provide some specific testing panels, can help you to identify and to guarantee the health of your patients as well as your preference. So that's my talk today. Thank you. So is there any questions from the audience? Okay. Okay, we got some questions. So on determine the cause of the animals, what equipment needed, if already have a microscope, blood. Okay, we have some questions, so maybe we can try to discuss online. Okay. Okay, here is one question about if we want to diagnose the animal with if we suspect the animal suffer from coagulation problems, and what equipment is needed. So basically, I think what we have, the basic tool is about just like the question have already mentioned about the blood routine test. So we can see the amount of platelet, and we can use the blood smear. It can help us to identify if any artifacts of the platelet, if the platelet they place well, or they have some over aggregate. That's what we have. Also, we can do the aPTT test, and we can use TEG, the equipment that right now we use most of the cases. As well in our teaching hospital, actually is TEG, because they help us to monitor all the procedure of the hemostasis. So I basically will suggest the TEG to use. Yes, there is a question related to the rivaroxaban dosage for dogs and cats. Actually, right now I don't have the detailed data about the dosage, but I think if you refer to the some specific guideline of the, if you have this kind of drug, and they will have you the data sheet to guide you about the specific dosage for dogs and cats. But actually, yes, because these dogs, if some, just I mentioned, if dogs, for example, they are MDR mutant dogs, they may very sensitive to the specific drugs. So you may need to really know the situation of your case, and to know the proper monitor will be needed. So just as I mentioned, if you want to have some, I think we don't need to, if we want to diagnose about the coagulation problems, I think basically we just want to know from the very beginning. We just want to know the platelet amount. We just want to know the function, the morphology and the aggregation situation of the platelet. So that's what we can use some just typical on the blood cell counting machine, and as well as we can do some blood smear. But if you want to have a further knowing, you can have some equipment, the TEG I mentioned, and some equipment that they will help us to monitor to measure PT and aPTT time. But if the case is complicated, such as I mentioned, the cases is some inherited, some gene mutated cases. If you suspect your case is this kind of a result from gene mutation, you may need to ask the help from some central lab in your country or in your location. It will help you to better understand if there is some specific pathogenesis of this case. I think you can get the PowerPoint, you can get the PDF file today from the Bioguard. I think they will provide you, I think. Okay. Here's a good question that how do we know if the bleeding problems actually how do we differentiate if the bleeding problem is result from the blood parasites such as Ehrlichia, such as Babesia, or these cases suffer from a VWD. So just as I mentioned before, that I think you got this kind of kit. You can to do some tick-borne vector panel, because this case Ehrlichia, Babesia, Anaplasma, and the Rocky Mountain sway fever, this kind of tick-borne parasites. Actually, right now we have a different kind of kit. This kinds of kits, they are easy to manipulate, to help you quick to get if the cases suffer from this parasite infection or not, just within maybe 15 minutes. But if another tool we use is about the PCR. You can use PCR and to help us identify this parasite as well. But basically, I think the most easy way is about to use the this kind of a very quick detection panel, and it can guide you. It can give you the result if this case suffer from the parasite infection or not. But for the VWD, actually we need to do some DNA assay, and we as well we have mentioned in the slide. Right now we can also have the ELISA kit. It's some kind of kit that help us to measure the amount of the VW factor, von Willebrand factor. So either parasite infection, either VWD, we have the commercialized kits to help us to differentiate your suspensions, I think. Small breed dogs. Okay, about the dosage problem, I think you need to refer to the proper textbook for you to get the proper dosages. Okay. So thank you for your questions, and thank you for joining me today. So I'm happy. Actually, I'm very happy to share my talk today, and I look forward to the future that we can see I can see everyone again in the future. Thank you.
Thank you, Dr. Lin, for delivering an outstanding lecture. We also extend our gratitude to everyone who joined us today. We look forward to welcoming you to our next webinar, and good night.
Thank you. Good night.